All. This is Dr. Mobeen Syed from drbean.com. Welcome to one more show. So I was doing a series on central nervous system and then on pharmacology where we discussed the blood-brain barrier. The point of that discussion was to show the structure of the blood-brain barrier and then talk about the medicines and drugs that help it. So I thought that is a discussion that we should do here as well. So let's start with this. This is the first part of this discussion. There are 2 or 3 topics that I would deliver over time. Today, we'll talk about the endothelium of the blood-brain barrier and the tight junctions in those endothelium, the basement membrane, and the functions of these. So let's start our discussion and welcome. My book has reached 20 chapters, I believe 92 diagrams left to go. So this is the clinical overview of the blood-brain barrier. Endothelium is the focus. So I have no disclosures, and let's look at the blood-brain barrier. From a high-level point of view, the blood-brain barrier has multiple layers. Compared to our normal vascular beds in the remaining body, where the capillaries do not have such protection and sealants on top of them. They're not sealed as the blood-brain barrier is. The reason for that is very simple. The brain says, I do not want anything from the circulation to arrive in my tissues because these things can harm me. At the same time, brain does need nutrition to come in and fluids to come in and waste products to be washed out. So we have a very interesting capillary structure inside the brain. And that is where the blood-brain barrier is formed. So here, if you see the innermost layer, this is a capillary. The innermost layer is the endothelium, or the flat cells that are facing the blood, or they're facing the lumen of the capillary. In this blood-brain barrier endothelium, if you see, I have a technical mistake over here. Normally 1, 2, 3, 4, or some more cells make a complete cycle around the capillary. But if you see inside, I have made like hundreds of cells, which is technically incorrect. But as an illustration, I made that. So my apologies, but here is a correction. So this is the endothelium. Blood cells are flowing in here. Outside of the endothelium is a basement membrane. All of our tissue cells, wherever they are, liver or pancreas or kidney or brain or vascular system, every cell needs to sit on a foundation. That foundation is called a basement membrane. Imagine if you put a piece of paper and then you put some eggs on top of it. The eggs will be the cells, and the piece of paper is the basement membrane. So here, because the cells need to be arranged in a circular fashion, the basement membrane here, which is looking in blue, is also structured that way, that it is a tubular structure. On the inner side are endothelial cells. Then, so far, this is a similar structure that is present in the other capillaries of the tissue of the body as well. We'll call them systemic capillaries. That is, they are present in the system. These capillaries also have endothelium, and they also have basement membrane, but that is the only similarity. You would see everything else is going to become different. In the blood-brain barrier, once we have done this, we go to brain and we say, is this sufficient for you that we have endothelium and basement membrane? And the brain says, no, not at all. This would leak substances from the circulation, the blood, towards my tissue. I don't want that. I want more protection. And the body says, okay, I'll put some more cells outside. And we call those cells the pericytes, the green ones over here. Pericytes are making another tubular structure on top of the basement membrane, outside of the basement membrane. However, they are more sparsely present. They are not present like a continuous layer, but they are present here and there on the capillaries. Also to note that this basement membrane, when it encounters this green cell, the pericyte, the basement membrane would actually split in two On the inner side, it is covering the endothelium, but then it would split and also cover the pericyte with it as well. So pericytes are kind of engulfed, embedded within the basement membrane. So then we go back to brain and we say, how about that? Now we have another cellular layer outside of the capillary, the endothelium and the basement membrane. You good with that? And the brain says, no, no, I'm still very afraid of this whole thing. We need more protection. And so then what we do is we have another cell in the brain, which is called astrocyte. And it is called astrocyte because it looks like a star. And the astrocytes are star-looking cells. Why does it look like a star? It is a cell with a body, and then it has multiple branches coming out of it, like rays of a star. And these branches then become expanded at the end, sort of making the feet of these cells. These ends then expand, and they also create a covering around this tube of the capillary. So again, these blue layers here, they do create a continuous layer around the tube, internal tube, which is a capillary endothelium, basement membrane, and pericytes. However, the gaps between these cells are a little loose. They're not completely closed, but they are sufficiently closed that the substances from the brain cannot enter the blood circulation, and the substances from the blood circulation cannot just simply leak out. We are doing all of this to protect the brain tissue from substances and molecules coming out of the tissues and entering the brain tissue, coming out of the vascular system and entering the brain tissue. So I hope that this is clear. The next diagram is what I'm going to discuss today. Today, I'm only going to talk about the endothelium and the basement membrane, primarily endothelium, and no pericyte discussion, no astrocyte discussion, no perivascular space discussion, no glymphatic system discussion. These are separate discussions. They have separate diseases, and they need to be looked at separately. If I started doing that, I think we'll spend 2 or 3 hours. So I am going to try to do as fast as possible within the endothelium space. So next, look at these two sections of two capillaries. The top section here is a systemic capillary that is present in our body. So in here, these rather purplish cells are the endothelial cell. Inside the reddish area is the lumen of the blood vessel or the capillary. And as you can see, that there are gaps between the cells, although in the real capillaries, those gaps are not so pronounced the way I have made them. But the point is that there is space between the cells from where molecules can get out or come back into the capillary. So I would say that they are rather permeable, not fully permeable to everything, but selectively permeable. These are called gap junctions. So there are junctions between the cells. So this is one cell and this is another cell, and there is a gap between them. So that is a gap junction. On the other hand, if you look at this structure below, this is just the endothelium of the blood-brain barrier. This is the basement membrane. Ideally, this is kind of a tube here. So I have a section of it. This is a basement membrane. This is a basement membrane. But the pericytes are not present. The astrocyte foot processes are not present. The perivascular space is not present. The glymphatic system is not present. Just the endothelium. And if you see here in the endothelium, do you see that these purple cells here, they have these tiny lines that I've made. These are called tight junction proteins. They make tight junctions. So here, this is in 2D. I'll try to explain to this in 3D as well. But for the time being, the difference from the systemic capillaries is that we have 3 proteins over here, claudin, occludin, ZO1. So what happened was we went to the brain tissue and we said, okay, the systemic capillaries have gaps between the cells. What do you think if we actually put a network of threads between the cells and try to seal the cells, try to pull the cells together like a zipper with this little set of threads. Would you be happy with that? And brain said, okay, that looks better, but I still need more protection. I still need more verification, more, more sealing. So we say, okay, we have put the claudin over here. Claudin is a protein that makes these thread-like structures between the endothelial cells to kind of try to seal the gaps between them. Then we say, okay, we'll put occludins there as well. These are also proteins that are present between the cells and in the gaps, and they originate from one cell and they go to the other cell, and they kind of have thread-like structures, and many of them together would make a weave that would help to create the seal as well. So that is occludin. And we go back to brain and we say, are you feeling comfortable now that not much things would come out? And brain says, no, not yet, I'm still not comfortable. And then we put in one more protein called zona occludens, or ZO1. So when this happens, brain says, oh, very good, I feel I'm completely good now. These cells are completely sealed. So all good. And then we pose a question to brain and we say, okay, fine, we have sealed the vascular system. Nothing can come out of it to your tissues, and nothing from your tissue can get into the vascular system. But how would we give you glucose? And how would we bring water to you? And how would we give you amino acids that you're going to use to make enzymes and other proteins? How would we bring in lipids that would become part of the myelin sheath? What would happen? And brain starts thinking, and it is the wise one. So it said, you know what? I should have specialized transport systems. So here is what happens. Now that, think about it, the blood-brain barrier is a sealed product. Nothing can come out of it and nothing can go it. However, we have to feed the brain. We have to provide nutrition to it, oxygen to it, and we have to wash away carbon dioxide and other waste products. So look at this area. Brain have some specialized mechanisms to receive very selectively, excuse me, very selectively the molecules that it would like to have, like glucoses, amino acids, lipids, and insulin. Remember, brain tissue also has cells that need insulin to work on them to pick up the glucose. So insulin need to get in and other substances need to get in. So what do we have? First of all, look at this area. This is the transcellular diffusion. Transcellular diffusion means that some molecule that is present in the vascular system passes through the cell, then floats inside the cell and comes out on the other side towards the brain tissue. It is called transcellular. Why trans? Through the cell. Now, molecules that are going to go through the cells, they have to have a very specific structure. They have to be lipophilic, lipid loving. Why do they have to be lipid loving? Because the cell membranes of the endothelium cell and all of our cells are phospholipids. They are oily. They would not allow water soluble things to pass through them. So we have to have lipid soluble items that can just diffuse from the membrane inside the cell, and then from inside the cell to the other membrane and come out on the other side. This is called transcellular diffusion. The molecules have to be lipid soluble. And this poses a problem here, which I would like you to start thinking about, and that is many of the antibiotics, for example, or drugs, majority of them are water soluble. Why are they water soluble? Because we have to drink them with water and they have to end up in our GIT, and then from there they need to be absorbed and circulate in the body, and majority of our fluids are watery. So we cannot have them distribute thoroughly and correctly if they are not water soluble. So this is why many antibiotics can actually not reach the brain tissue, because they are water soluble, and brain tissue would allow molecules that are lipid soluble. So this is transcellular diffusion. The second type of transport of molecules from the vascular system, blood circulation, into the brain tissue is called facilitated or active transport. In the facilitated or active transport, what happens is that so imagine that this is a cell, one endothelial cell. On one side of this cell, we will put an energy dependent pump that would throw something out from within the cell to the brain tissue. Let's say this is sodium. Now remember, sodium, potassium chloride, magnesium phosphates, these are charged molecules. So they cannot enter the blood-brain barrier because they cannot cross the blood-brain barrier without help because they're charged. Charged particles are usually water soluble. So if we want sodium to get into the brain, which is very important because action potentials or electrical activity of the brain does need sodium to happen, we will need to do something like this. We have an ATP pump, energy using pump, that would throw sodium out into the brain tissue. That will reduce, the result is that there is reduced amount of sodium within the endothelium cell now, so lesser concentration. And then we would have towards the blood side, so let's say this is the capillary. On the capillary side, we will have sodium and we'll make a passive pump over here, not pump, sorry, a channel over here through which sodium can get in. So now on this side, you continue to pump sodium out into the brain tissue by force, by spending energy. You're actively throwing them. And that creates a concentration reduction inside the cell, which then gives a, what is that? Uh, diffusion gradient for the sodium to get into the cell. So this is called facilitated transport or active transport because the active mean energy spending. So then after the facilitated transport, brain has more mechanisms. So there is a receptor dependent transcytosis. In this process, what happens is, if I hide this once more and I develop this endothelial cell over here, and let's say this is the brain side and this is the capillary, what happens is that the cell has a receptor for something, let's say for insulin. This is not the insulin receptor that allows the glucose channels to open, but this is an insulin receptor that would help insulin cross the cell. So here we have a tiny boat for insulin, like if you have to cross a river, the insulin molecule would come and attach here, and then this whole complex of the receptor and the molecule is internalized or endocytosed, as we say, and this little boat or this complex would then travel through the cell. It is transcytosis through the cell, end up on the other side and release the molecule towards the brain. So this is the second kind of or third kind of transport, receptor dependent transcytosis. Trans, once again, means through the cell, just like you saw here, transcellular, here transcytosis. It is the same thing. Transcellular means through the cell, transcytosis, cyte means cell as well. Transcytosis means through the cell as well. Then the brain has one more, the blood-brain barrier has one more type of transport, which is very interesting, and I made it in reverse over here. This is called efflux transport. In the efflux transport, what happens is that, let's say this is some molecule, some cute molecule here in the vascular system, and it is lipid soluble. So it knows that I can happily just diffuse through the cells and get into the brain tissue. So it is pretty happy. And it is, let's say, toxic for some reason. And it is coming into the vascular system and saying, I'm going to get into the brain and cause damage. But what happens is, as soon as it enters a cell, the cell has special proteins that would capture it, arrest it. And then it has special energy spending pumps that would actively throw it out again. So this is like if you have somebody brings in groceries in the home and they put the groceries in and you put the bag out, and then they put the groceries in again and you put it back out. So that is the efflux transport. So efflux transport helps the blood-brain barrier kick out the molecules that are trying to sneak into the brain tissue, and they're taking advantage of being lipid soluble. This is also the reason that some of the antibiotics cannot reach the brain, even if they are lipid soluble, because, or other drugs, even if they are lipid soluble, and we trust that they can enter the brain, and they're still not able to enter it because the efflux transporters will pick them up as soon as they enter the endothelial cell and throw them out back in the blood. So you bring something in and they just kick it back out. So these are various mechanisms of transport This allows the brain tissue to very carefully select whatever it needs and reject everything else. Even water cannot enter the brain like it does in the rest of the body through the capillary gap junctions and out. Even water is not allowed. So there are specialized channels inside the um, astrocyte foot processes. These channels are called Aquaporine channels, or AQP4, I believe. And these channels are responsible to bring water out or back in. Even water is not allowed. This is how tightly the matters are controlled. Now, if you think about it, if with such a tight controlled border, there is a leak in it, there is a permeability in it, imagine how much damage can occur to the brain tissue. Okay, so back here. Now, this is another diagram, rather simplified illustration. So imagine that this is one endothelial cell, a little crooked cell, but I'll explain why it is crooked. And this is another endothelial cell. What happens is, do you see these structures between them? They are claudins and occludins and zonooccludins. What these structures do is that they make these threads between the cells, and there are such numerous number of threads that they almost make a weave, a zipper between the cells, and they close the cells. So what happens is, when they are closing the cells and they are present between the cells inside of the cells, we have cytoskeleton and specialized proteins with which these threads are anchored. Just like if you have a bridge, and the bridge has those anchoring wires on it, or ropes on it, I do not know what they're called, but then they are anchored in the ground, correct? So similarly, within the cell, there are specialized proteins in which these claudins and occludins and other proteins are anchored. When this happens, these proteins kind of pull the two cells together in the place where these proteins are present. The tight junction proteins are present, that causes the cell membrane to be pulled towards each other. This point where the cells are pulled towards each other, almost to touch each other, this point is called the kissing point, because over here the cells are kissing each other. So there is this kissing point, and then there is this kissing point, and there could be multiple others. So one more way to show this, so imagine that this is the endothelium, one endothelial cell, this is the other endothelial cell, and this is the membrane between them. And normally there is a gap between them, but if you see these structures over here, so let me just reduce the noise on the diagram. If you see these little structures over here, these are the claudins and occludins and ZO1s or zonooccludins. They are pulling these cell membranes towards each other, creating the kissing points and kind of sealing the cells together. Here is another similar weave of these threads. Aim says, "Hi doc, awesome art. Thank you very much. I spent a lot of time to make these diagrams. However, I hope this makes it clear compared to what we have over here, that here there are just some thread-like structures that are anchored into the cell. I think this is a more clearer three-dimensional structure, how the endothelial cells are pulled together and their membranes kiss each other to kind of close the space between the cells. And this is a very important part of the blood-brain barrier. Okay, continuing. Some examples of the transport systems, these transport systems that we saw: transcellular, facilitated, receptor dependent, efflux transporters. So some examples are transcellular diffusion is lipid soluble things, for example, oxygen, carbon dioxide, chloramphenicol. These are all lipid soluble, and they can just transcytose. They can go from one through the cell membrane, because these are oily things, or they can love lipids. Then is the facilitated or active transport. Glucose is a huge example. So we have glucose transporters that throw glucose actively out towards the brain tissue, and that allows the uh, glucose to move from the cell, from the circulation into the cell and move on. Similarly, amino acids. Brain needs amino acids to make proteins. Amino acids are building blocks of the proteins. So there are special transporters called LAT1 transporters or LAT1 transporters, which help with that. Then receptor mediated transcytosis. For example, insulin, as I gave this example before, insulin would come in and attach to the endothelial cell of the blood-brain barrier on the insulin receptor, but this is not an insulin receptor to open a glucose transporter, but instead it would pull the insulin and help it, like a little boat, help it pass through the cell to the other side towards the brain tissue. Then efflux transporters, these are critically important pumps. And for example, there is a pump for P glycoproteins. And this pump would throw out anything that is a molecule or derivative or substrate of P glycoprotein or derivative of P glycoprotein. So many drugs, if you are a provider, when you are giving some drug, thinking of administering some drug to the patient, you have to make sure it is not P glycoprotein derivative, because even if it is lipid soluble, it cannot enter the blood-brain barrier and into the brain tissue. Now, clinical significance. Diagrams are done. Jim says, I appreciate your work. I feel blessed to be your friend. Thank you very much, Jim, and same here. So, endothelial layer. Now we are talking clinical side. Remember, I said only the endothelium we'll discuss today. So we are just talking about the endothelium. We're not talking about the pericytes and not talking about the astrocytes and not the perivascular space and the lymphatic space and so on. So, endothelial layer clinical significance. First of all, we have in pharmacology, we have a measurement system called drug penetration prediction. What that means is that imagine if you are a research worker in a pharma industry and you're thinking of making a molecule, or you found a molecule that you think would help the brain tissue, and now you are curious that will it pass through the blood-brain barrier and enter the brain tissue or not? So what you can do is you can check that molecule's lipid loving ability, how lipophilic it is, and how hydrophobic or hydrophilic it is. So based on how much a molecule loves lipids, the more it would love the lipids, the more it can enter the blood-brain barrier easily, and less love for the lipids or oils, less easily would it enter the blood-brain barrier or pass the blood-brain barrier. So this measurement of lipophilicity of a molecule is called drug penetration prediction. So there is a scale from 1 to 3, the 1 being the least loving, and anything below 1 cannot penetrate the blood-brain barrier at all. That is like it doesn't love the lipids at all. 1 will be minimum loving ability of lipids for a molecule to enter the brain tissue. 2 is, of course, better than that. And that a drug that has a drug penetration prediction of 2 will actually become available more to the brain tissue compared to something that is 1. And of course, 3 is even more. So you can actually check the molecule's drug penetration prediction to see how much of this drug will enter the brain tissue. Chloramphenicol is an example, for example. So when you are prescribing a drug, you may have to make a decision to say, what is the lipophilicity of this drug? Okay, next. Stroke and ischemia and the role of the blood-brain barrier, especially the endothelial layer. So remember, in the stroke and ischemia, especially in the ischemia, what happens is that the nutrition and the oxygen to the cells is reduced. So imagine that happens to the endothelial cell as well. So when the oxygen and nutrition is reduced, what would happen is, so let's say this is a cell, this is an endothelial cell. Although endothelial cells are more fried egg-like flat cells, but let's use this example. Imagine this is an endothelial cell. Endothelial cell, like any other cell, need to continuously recycle their components. So we have a cell membrane, phospholipid membrane, and there is a continuous need to recycle this cell membrane and make new cell membrane and put that in. Then all the other membranes for the nucleus and the mitochondria and the Golgi apparatus, they need to be renewed all the time. Then the enzymes that are present in the cell that are doing various functions, they need to be recycled. Enzymes can live anywhere from hours to days. So whenever you need to have an enzyme that would do something, you need to make it again. You need to recycle it. The cell membrane is replenished, all of it, within 15 days. Now, for that, the cell needs ATP. And to make ATP, it needs nutrition like glucose, and it needs oxygen. So when a cell is in an ischemic state, where it is not getting enough blood into the tissue, where the cell itself is not getting enough oxygen and nutrition, then what happens is cell's ability to make new membranes, to replenish the membrane, recycle the membrane, to repair the membrane, to create new enzyme, to create new microtubules, to repair the Golgi apparatus, to repair the smooth endoplasmic reticulum, rough endoplasmic reticulum, ribosomes, that whole ability falls apart. So what happens? The cell would start losing integrity. And what would happen is, for example, the cell membrane would start developing holes in it. Why are there holes developing in the cell membrane? Because the cell could not produce new membrane to patch there. And when those holes start appearing, guess what is sitting outside? Sodium. Sodium loves to come into the cell. Why? Because the cell's interior is very negative in general. Why? Because there are proteins in there. Proteins are negative. So sodium loves to get in. When the sodium would get into an ischemic cell, water would follow. Water loves sodium. Water loves glucose. So water would follow. And what would happen is this cell would start swelling up. When the cell would swell up, its holes in the membrane, the integrity issues will become pronounced. This is like a balloon which has a small, tiny hole in it. And if you stretch it, that hole would look bigger. So all of a sudden, there will be fluids that are getting in, and there are fluids that are coming out, and there are bad substances that are going in. The whole cell is now going to die. So imagine this is an endothelial cell. When this happens, remember, between the two endothelial cells, we have the tight junction proteins. So when we do not have enough ATP to maintain them, this is like we do not have enough resources to maintain the ropes that are anchoring up. So when there is not much ATP available, the anchoring protein, the tight junction proteins, will die as well. Right? So when the tight proteins will be broken, what will happen is the gap between the cells, endothelial cells, would start becoming apparent. It would become open. The sealant between them, the zipper between them, is gone or is damaged. And as soon as that happens, from the vascular side, from the capillary, the not so good substances would start entering the brain tissue. And if we do not get control of this situation fast, the more harmful substances would enter the brain tissue, the more inflammation in this area would occur. That would cause more immune cells to start damaging, and more of the blood-brain barrier would start opening up and becoming damaged. This is why it is important that during strokes and ischemia, we make sure that that area, for example, if this area, these cells were dying because there was a clot stuck in the blood vessel, and that was reducing the blood supply to this area, downstream areas, it is important for us to use, for example, thrombolytic things to reduce and remove the clot, or to provide oxygen, or to provide the nutrition, or try to make sure that the blood supply is opened to that area. At the same time, the doctors in ICU have another problem. If they give too much thrombolytics, if they dissolve the clot with lots of vigor, they may make the blood so thin, and they make the blood flow so much that the blood would now start flowing into the brain from this damaged blood-brain barrier. And that is now a hemorrhage. So you can imagine how sensitive it is and how delicate it is to manage a patient of ischemia and stroke. So if I go back here to the diagram, to the slide. Stroke and ischemia. Tight junction proteins, claudin, occludins, they break down within 30 minutes. Matrix metalloproteinases degrade junction proteins. So these are enzymes that become activated, which are called matrix metalloproteinases. They would start eating away at those little junction proteins that we saw here. These guys would start getting eaten up and degraded, and that would create permeability of the junction, which would then bring in the bad things into the brain tissue. Then the vasogenic edema would occur. Vasogenic edema means that, imagine that this is the brain tissue, and this is a blood vessel, and these are the endothelial cells, and we have some tight junctions that have broken. Now, water and fluids and things are seeping in. The blood cells are not going in there. It's not a hemorrhage yet. But because the permeability of the blood-brain barrier has increased, the molecules and water are now flowing freely towards the brain. That would create edema in the brain. And remember, brain does not like edema or any other volume that would compress in the brain tissue. So now we have this is called vasogenic edema, where the fluids are seeping in from the blood vessel into the tissue. There can be cytogenic edema as well. And I discussed that before. When ischemia happens to a cell and the cell starts swelling up and then it would start giving up its fluids, that would also cause edema in the local tissue, and that would be the cytogenic edema. But more, what is that? Freely speaking, or more loosely speaking. Okay. So then after stroke and ischemia, you can imagine how important it is to keep the blood-brain barrier's integrity during stroke and ischemia, and improve the situation, the nutritional situation or oxygen situation, and to be able to wash away the waste products and carbon dioxide to reduce and limit the amount of damage that would happen to the blood-brain barrier. Then clinical recognition. The blood-brain barrier during stroke or ischemia, if it continues to become more and more, that would create a risk for hemorrhage, as I said before. Similarly, this CT MRI shows edema progression. So especially gadolinium enhanced MRI or T1 weighted MRI, that would show you where the blood-brain barrier problem is. Why does it do that? Imagine that this is the blood-brain barrier, this is a capillary, and this is the brain tissue. Something is happening here. And the endothelium, the tight junctions between the endothelium have broken down. That would allow various molecules to start seeping in. Gadolinium is a rare earth, which is called paramagnetic. Paramagnetic. What that means is that wherever this little molecule is present, it increases or amplifies the magnetic signals. So when gadolinium is given, and if there is any compromise in the blood-brain barrier, then that gadolinium would enter the brain tissue and be present in the brain tissue where the fluids should not be, meaning vascular fluid. Otherwise, brain tissue has fluids. Now, when you do MRI on top of it, the magnetic signals are enhanced, and so this area would look hyper intense, or the area where the blood-brain barrier is compromised and the fluids are seeping into the brain tissue, that is where gadolinium would be present as well, and one can see hyper intense or white area where there should not be whiteness. Of course, when the gadolinium is present within the vascular system would look white. But if parts of the brain tissue start looking white as well, that means there the blood-brain barrier is compromised. Then timing of the thrombolytic decision. As I discussed before, the doctor has to make a decision to say, when do I give blood thinners and how much blood thinners? And if I take away the clot, will it cause hemorrhage in the brain because of the sudden reperfusion? And if the blood-brain barrier is not yet fully integral, or if I do not give blood thinners, would I cause more damage to the blood-brain barrier? So these are the kind of very delicate decisions that the ICU doctors have to do. Continuing, we are talking about endothelium, just the endothelium of the blood-brain barrier and its importance. clinical importance. Then infections and inflammation. What happens is, normally, as you saw, that the blood-brain barrier is made with such care that molecules cannot enter the brain tissue from vascular system. So imagine if there is an infection in the brain and you're trying to give an antibiotic that needs to get into the brain and kill that infection or pathogen or worm or whatever it is. But turns out the antibiotic cannot cross the blood-brain barrier. Now we become lucky during the meningitis, for example, or inflammations in the brain, that when the inflammation occurs due to infection or other reasons of inflammation, the blood-brain barrier starts becoming compromised and starts opening up. Especially the interleukin 6 and tumor necrosis factor alpha that are produced in the area of inflammation in the brain, they open up the blood-brain barrier cells. How do they do that? So if I quickly draw this, imagine that this is a cell, endothelial cell. This is another endothelial cell, and they have these tight junctions between them. When the tumor necrosis factor alpha and the interleukin 6, they bind to the receptors on these cells would internally produce a lot of reactive oxygen species, or other inflammatory pathways will become activated. Superoxide dismutase production might reduce. The result is that this reactive oxygen species would start attacking various things in the cell, including the blood-brain barrier tight junction proteins like occludins and claudins, etc. That would break these proteins, that would open up the blood-brain barrier, and now it is open enough that antibiotics can enter the brain tissue. So fortunately, in the case of infections, meningitis, inflammation, blood-brain barrier has already become permeable to allow the antibiotics. This is why penicillin that does not normally cross or has very low availability for the brain tissue in a healthy person becomes useful during the meningitis, because the blood-brain barrier is compromised. And this is also important then, that during the blood-brain barrier permeability increase for inflammation or infection, you don't go ahead and start giving steroids vigorously to close the blood-brain barrier. Although remember, in meningitis, steroids are given so that the scarring does not happen and patient doesn't end up with permanent meningeal damages and the tissue damages. But still, the doctor has to be careful not to close the blood-brain barrier. Otherwise, as soon as you reduce the inflammation and the blood-brain barrier closes, but if the infection is still present inside, now the drugs are not going to enter the brain tissue. So you will have to have that delicate balance of deciding how much steroids to give and how fast to give antibiotics. This is why even if you have a suspicion of meningitis, you start empirical medication right away. You start treating right away, because the time is of the essence. Blood-brain barrier is open. You can send the antibiotics in. As soon as blood-brain barrier starts closing, you cannot send the antibiotics in. And if the pathogen is sitting in there and causing damage, it would continue to do that. This is why sometimes it is difficult to manage worms in the brain. The problem with the worms is that not only the sending the drugs in is difficult because the blood-brain barrier is healthy. The second problem is when you kill the worm inside a brain, the worm being a very large structure, when it breaks open, it would create so many damage-associated molecular patterns. It would create so much of trash in the brain tissue that the brain's immune system would become activated and start killing the neurons. Okay, so anyways, clinical monitoring. So what you do when the blood-brain barrier in an inflamed patient or in a meningitis patient or infected patient, when it opens up, of course, the white blood cells start entering the brain tissue as well. Remember, there is inflammation there, which attracts the white blood cells, and the blood-brain barrier has become permeable. So the white cells would now cross through the blood-brain barrier, compromised barrier, and enter the brain tissue. They would end up in the cerebrospinal fluid or CSF. So in this kind of a situation, you can take the patient's CSF and measure the pleocytosis, or the amount of white blood cells present. Normally, there are less than 5 white blood cells per microliter of the CSF. But in such cases, in meningitis inflammation, that would increase. And we already talked about the antibiotic and their penetration. Then aging and degeneration of the blood-brain barrier. So what happens is with age, and this is a completely different topic, that why does age do it? What is the role of the misfolded protein aggregates and reactive oxygen species? I've done tons of discussions about that. Here, I'm just going to say, when we are aging, our protein production capability is reduced. Our cell maintenance capability is reduced. So blood-brain barrier starts becoming more permeable. So a person at 60 would have more permeable blood-brain barrier compared to a person at 30. What does that mean? That means if you give a drug to a 30-year-old and you are comfortable that it will not cross the blood-brain barrier, the same drug in the same amount in an older person might actually cause damage to the to the brain tissue, because their blood-brain barrier is more permeable. Similarly, if a healthy individual at 30 eats something fun thing and they're okay, the same thing may be eaten by an older person, and those molecules might enter the brain and cause deliriums, because their blood-brain barrier on a baseline is more permeable. And that is a similar problem with Alzheimer's and dementia as well, that the blood-brain barrier is compromised. Nowadays, with the uh, long COVID, post-COVID vaccine syndrome, blood-brain barrier, because of systemic inflammation, especially then the antibodies against the blood-brain barrier uh, can cause persistent chronic inflammation of the blood-brain barrier, which would then cause more and more harmful substances to enter the brain tissue, which would cause early dementia, early Alzheimer's, and so on. So it is important for us nowadays, after this huge, bad, evil event that passed, the COVID time, still going on, that we have to make sure our inflammations are controlled. Okay, so next, the clinical implications of the age-related permeability. So drug dosing need to be adjusted in these patients or persons. Deliriums may happen. CSF to plasma albumin ratio increases. Just like albumin is not present in urine or very much in trace amounts. Similarly, albumin is a small protein that is present in the circulation, which does not cross the blood-brain barrier and enter the brain tissue. However, in older individuals, the presence of albumin in the CSF would tell us how much permeable the blood-brain barrier is. So there is a test for someone you are curious about, that, hey, how permeable their blood-brain barrier is. You can get their CSF to plasma albumin ratio, and that would tell us the health of the blood-brain barrier. And then we have already talked about meningitis. Um, as I said, interleukin 1 beta. Did I say interleukin 6? Interleukin 1 beta and tumor necrosis factor alpha cause the cells to become inflamed and activate the inflammatory pathways within the cell that causes reactive oxygen species to be produced, which would then cause the damage to all the cellular structures, including the tight junction proteins, that would break the tight junctions, and that would create permeability of the blood-brain barrier. However, that opening of the blood-brain barrier is also useful to have the antibiotics pass through it. For example, some examples of the antibiotics: penicillin G, normally in a healthy individual, less than 1% penetrates the brain tissue. But in an inflamed tissue, 5 to 10% of the penicillin can actually enter the brain tissue, which is sufficient to handle infections. Vancomycin normally cannot cross blood-brain barrier. However, in an inflamed blood-brain barrier tissue person or patient, the vancomycin, enough dose can actually enter the brain tissue through the compromised blood-brain barrier that can be therapeutically sufficient. Ceftriaxone, same thing, does not penetrate at baseline, but then it can go up to 3 to 5 fold from the baseline. It's not that it does not penetrate, very tiny amount. So the treatment strategy for meningitis, for example, in the context of this blood-brain barrier endothelial layers and the tight junctions and the opening of the blood-brain barrier, don't wait for the inflammation to resolve to give antibiotics. You would actually be countering the problem or amplifying the problem now. Blood-brain barrier is closed. How would you get your drugs in the brain now? Higher doses needed than for systemic infections, because not 100% or 80% or 50% of the drug is available for infected area. Only 5 to 10% gets into the brain, even after blood-brain barrier compromise. Some drugs still cannot access. Remember the efflux pumps? So aminoglycosides cannot enter. So don't give them as a treatment for meningitis. Then I talked about the gadolinium enhancement. Gadolinium is that rare earth which is paramagnetic, amplifies the signal, creates hyperintense or whitish areas in the brain tissue if there is a leakage of the blood-brain barrier. Now that can be useful in multiple ways. Number one, if doctor finds the areas of the blood-brain barrier that are compromised by doing gadolinium enhanced CT scan, or sorry, MRI, then they know I can give antibiotics and they will cross from here and enter the brain tissue. Secondly, the kind of signal that is created. So imagine if the gadolinium is given and a signal, a circular ring-like signal is produced. That means there is some structure here around which bleeding is happening, is occurring. This must be a tumor most of the time. Why? Because tumor releases VEGF, vascular endothelial growth factor. Vascular endothelial growth factor causes new blood vessels to start forming around and inside the tumor. These new blood vessels that are sprouting, they are not connected closely yet into the whole system, so their mouths are still open from where the fluids are leaking. So the pattern of the gadolinium enhancement would also tell us for what kind of lesion may be present in the brain. So T1 weighted post-contrast MRI with gadolinium. Then gadolinium enhancement shows active disruption of the blood-brain barrier. That may be useful for a doctor to know for where the drugs will penetrate in the brain and where they will not. And then enhancement pattern, for example, ring or nodular or leptomeningeal, would tell you the kind of problem within the brain. And then serial imaging of the brain with the gadolinium enhanced MRI will tell you if the blood-brain barrier is becoming more and more compromised, or if the barrier is becoming more and more healed. So gadolinium enhancement, if you suspect for someone that the blood-brain barrier may be compromised, one of the tests to do, other than the albumin CSF ratio, CSF to albumin ratio, is gadolinium enhancement as well. So this is just the quick note over here, the summary. So when you need CNS drug penetration, check if your drug is B glycoprotein substrate, if P, not B, P glycoprotein substrate. If that is the case, it's not going to get into the brain because it is thrown out by the efflux pumps. Then secondly, check if it is hydrophilic or lipophilic, and what is the lipid penetration process. Now at the end, an interesting thing I want to show you from the let's go here all the way. From long COVID point of view, vaccine, post-COVID vaccine syndrome point of view, the antibodies that are produced during long COVID have been seen to be against the endothelium, that is one, against the ACE2 receptors that are present on the endothelium, that is two, against the tight junction proteins directly attacking the tight junctions, that is three, against the astrocyte foot processes, that is four, against those aquaporine channels, AQP4 channels, which are very important channels to allow fluids to come out or in from the brain tissue and have other molecules like glucose to come out. If these channels are compromised, the whole brain would have a problem. And there are antibodies that are produced against these as well. So from a long COVID point of view and vaccine side effects point of view, in some people who develop these diseases, there can be the antibodies that are targeted to blood-brain barrier. So this is why it is important to keep in mind that if somebody has neurological symptoms from long COVID or post-vaccine syndrome, and you suspect brain tissue inflammation, an important first step is to figure out what is the health of their blood-brain barrier and try to make their blood-brain barrier healthier so that the permeability of the blood-brain barrier is not increased, and so that these antibodies cannot enter the brain tissue and not cause harm over there. So this is the discussion. Thank you very much for being here. Please like, subscribe, and share if you would like to. Comment as well. That is good too. And I'm going to be traveling for a week. So hopefully next week I'll see you with another lecture. And in the meantime, please stay healthy. And if you have any questions regarding blood-brain barrier, put them in the comment. And when I come back and do a follow-up for parasite and astrocyte, I will discuss those at that time. Thank you and have a good night.